and chair of his committee. His committee members are here, and they're wonderful. Dr. Zim McCullough, Dr. Gina Lauer. Nate will probably have some more things to say about us. Which is just fun. This is a really important day for Nate. He's been working really hard to earn his doctorate in nursing practice. And he's just about there. Over 5 years, 5.5 years. And I've known you for in this journey for 5.
Yeah.
Something like that. So it's flown by. At times it seems a little slow. That would be my daughter in Europe. So we're just going to ignore that. Decline. She'll know. And hope that she doesn't call back. Just in case. Hi. Join us.
Wow.
This is a public defense.
Yes, I'm in the right spot.
You are in the right spot.
No, you're okay.
Okay.
This is Dean Heath, our fearless leader. I was just telling the group that this is a special day in Nate's career. He's going to finish his DNP, and he's been working on this for quite a few years. He's going to present to you a culmination of work that he's been working with, a lot of independent work, but the thing about these projects is you can't do them on your own. It takes a village. So he's been working with his committee, but I think more impressively, he works with other disciplines at the hospital. And I'm going to let him tell you everything because it's pretty awesome what he's doing. It's very unique, it's very special. I'm very proud of him. Nate, you're on, buddy.
All right. Thank you all for being here for such a huge day in my life. The title of this presentation is the 2013 Jin Shin Jitsu Patient Response. Jin Shin Jitsu. From here on out, I'll refer to it as JSJ. First, I would like to thank each of these fine people for their help in this project. Each has been priceless in their own way. I really do mean that. Appreciate you all. This presentation will tie together 3 manuscripts that I've written. Manuscript 1 is a concept paper that discusses cancer-related pain, barriers to pain management, and the effects of pain on quality of life. Manuscript 2 is a review of literature on energy therapy. Specifically, this literature review explores research regarding the effects of acupressure, JSJ, and Reiki on pain and stress. Manuscript 3 is a report on a retrospective chart review of data from the year 2013 gathered from the JSJ program at the Markey Cancer Center. Overall, the purpose of this presentation is to bring about awareness of the issues surrounding cancer-related pain and its under-treatment, and to encourage the integration of energy therapies for managing pain and stress in the oncology population. First, I'd like to point out the fact that cancer is common. Everybody knows somebody affected by cancer. After seeing how prevalent cancer is and noting on this slide how many of those with cancer experience pain, it is evident that this is a major issue, and unfortunately, it's often undermanaged. Additionally, and understandably, some patients with cancer experience stress. Another point of interest evaluated in Manuscript 3 that I want to introduce here is the concept of gender differences regarding the pain experience. There isn't much literature on the topic of gender differences in cancer-related pain. However, one article I came across stated men and women have been found to report similar levels of pain intensity when they experience chronic cancer-related pain. So what is cancer-related pain? This term describes pain in a patient with cancer caused by tumor invasion, surgical intervention, or painful sequelae of chemo or radiation. In the 2013 guidelines for managing adult cancer-related pain, the National Comprehensive Cancer Network, or the NCCN, discusses that pharmacologic analgesics are the foundation for management. These include opioids, non-opioid treatments such as NSAIDs, and adjuvant analgesics such as antidepressants and anticonvulsants. However, medications are not always well tolerated. Adverse effects of pharmacologic therapy oftentimes call for the addition of non-pharmacologic therapies, including physical, cognitive, and spiritual interventions. When these strategies are used in addition to conventional treatment approaches, they are oftentimes considered complementary or integrative therapies. To recap, cancer-related pain is prevalent and highly undermanaged. Now, I'll discuss Manuscript 1 and talk about barriers to pain management, which may be related to the provider, patient or family, or other factors. I'll also discuss the effects of pain on an individual's quality of life. Here are some provider-related barriers to pain management. Routine screening for pain should be performed in all patients with active malignancy, and those who report pain should undergo a comprehensive pain assessment and treatment plan. From my current work in acute pain management, I feel there is room to improve in regards to pain assessment skills and treatment plans in healthcare, at least in the inpatient setting. In regards to under-prescribing or under-administering medications, this could be due to the fact that providers are afraid of over-medicating their patients. They may also be afraid of their patients becoming addicted to pain meds. Providers may also not realize the benefits of adding antidepressants or anticonvulsants for managing pain. Even things that seem simple, such as Tylenol or ibuprofen, are often not included in the regimen. Also, a lot of interventional procedures can be performed by pain management experts, including nerve blocks, epidurals, or other procedures, but this doesn't always happen. A lot of patient or family-related barriers, as you can see here, involve fears. As providers, we need to have discussions with our patients and educate them to help ease their fears. Other barriers don't really fall into either of the previous categories. These include side effects to medications and comorbid conditions. Some side effects to medications resolve after a few days or can be managed by lowering the dose. However, they may quickly turn the patient off to taking the medication. Depression and anxiety should also be managed in order to improve pain control. With a very anxious patient, you can give them all the pain medicines in the world, but they won't perceive it as having helped their pain often. But when you get their anxiety under control, it's a game changer. The same goes for patients with depression. Pain management is important for many reasons, including the fact that pain affects a patient's quality of life. One of the goals of Healthy People 2020 is to improve health-related quality of life and well-being for all individuals. Pain and quality of life have an inverse relationship in the sense that as pain increases, quality of life decreases. In one study, the relationship between pain and quality of life was evaluated for patients in a hospice center. Those with mild, moderate, and severe pain intensities had average quality of life scores as noted on this slide. In the instrument they used to measure quality of life, scores range from 0 to 60. Less than or equal to 20 indicates the worst quality of life, and 51 to 60 indicates the best quality of life score. So what are some actions that can be taken to break down some barriers to pain management and improve pain control? I briefly mentioned a few already. One, we need to acknowledge these barriers and be aware if we encounter them in practice. Education is also an important tool for overcoming barriers. By improving pain assessment skills and having a good treatment plan, we can improve pain management among patients with cancer. Depression and anxiety need to be managed. Consulting those trained in palliative care can also be useful. Non-pharmacologic interventions should be utilized as appropriate, including relaxation training, distraction, acupuncture, physical therapy, and emotional support, among others. JSJ is another non-pharmacologic approach that can be included in a patient's plan of care. In the upcoming slides, I'll discuss non-pharmacologic strategies known as energy therapies and their role in managing pain and stress. The concept of integrative therapies was introduced when I mentioned the NCCN guidelines for managing adult cancer-related pain. Integrative strategies discussed by the NCCN include physical, cognitive, and spiritual interventions. Physical strategies include things such as massage, acupuncture, and acupressure. JSJ is similar to acupressure in that they both utilize gentle pressure on particular parts of the body to stimulate the body's energy flow. Cognitive interventions include things such as breathing exercises and relaxation techniques, which help the patient feel in control of their symptoms. And spiritual interventions can include whatever is consistent with the patient's belief system, which might be prayer or other rituals. The National Center for Complementary and Alternative Medicine notes certain complementary therapies have the intent of manipulating putative energy fields to affect health. Energy fields can be described as a network that integrates the functions and systems within a living organism and connects them with the energetic and physical functions and systems in the organism's environment. In energy therapy, a practitioner channels healing energy through his or her hands with the intent of restoring a normal balance of energy. Energy therapy is a type of integrative therapy based on the belief of a universal life energy that travels throughout the universe and within every living being. Some examples of integrative therapies are listed here. Some examples of integrative therapies that involve the manipulation of energy fields are listed here. The three with the asterisks are those specifically discussed within manuscript 2. The first one we'll discuss is acupressure. Acupressure is similar to acupuncture but without needles. Benefits may include things such as pain, tension, and stress reduction. In the literature, different acupressure techniques were found to be beneficial for different pain populations, including those with chronic neck and back pain, pain related to sickle cell disease, and pain related to a bone marrow biopsy. I'd like to highlight the findings from one study in which acupressure was compared to physical therapy for the management of chronic low back pain. This was a randomized control trial from Taiwan, and participants were randomly assigned to one of the two groups. There were no significant differences in demographics between the two groups. As you can see, there was a significant reduction in pain following acupressure when compared to physical therapy after 4 weeks of treatment. As noted on the previous slide, pain was assessed using a Chinese version of short-form pain questionnaires. This is not a 0 to 10 scale we're used to using, but a higher level still indicates worse pain. Also in this study, the authors said there were no adverse effects of acupressure noted. The acupressure group continued to have a greater response than the physical therapy group at a 6-month follow-up. It was also found that acupressure was more effective than the physical therapy techniques regardless of participant age or gender. The second energy therapy discussed in the literature review is JSJ. JSJ is based on an approach to life and healing which recognizes a life energy that animates all living things. JSJ practitioners believe the flow of life energy within an individual must be strengthened and harmonized in order to enhance physical and mental being. In JSJ, a practitioner uses his or her hands as jumper cables, contacting different safety energy locks with the intent of unblocking disruptions in the flow of energy along a particular pathway. There are 26 pairs of safety energy locks that are arranged symmetrically on each side of the body. The practitioners start by listening to a patient's energy pulses in his or her wrists. This is a strategy utilized in traditional Chinese medicine. The next steps involve the energy harmonizing sequences utilized by a JSJ practitioner, known as a flow. A flow is a distinct pathway in which life energy travels throughout the body. If an energy blockage, constriction, or stagnation occurs along the flow, the result is disharmony. Each JSJ session is unique to the individual patient. Different flows and energy locks are utilized based on what the practitioner senses as the specific patient's needs. These needs are determined based on the energy pulses, the physical appearance of the body, the patient's diagnosis, and the patient's symptoms. There's very limited published research in the utility of JSJ for pain and stress management in patients with cancer, and I couldn't find any quantitative data that spoke to these outcomes. I'll highlight the findings of a case report and a pre-test post-test study that I found. In the case report, a 56-year-old male received JSJ for pain in his ribs. He requested JSJ from his family member when pain continued to be unbearable despite NSAIDs. Following each session, the patient was able to benefit from a reduction or temporary resolution of his pain. Duration of relief varied from several hours to several days. This same patient also received JSJ for migraines. On one occasion, the migraine was eliminated following JSJ. Once, the intensity was reduced, and then 2 other times there were no notable improvements. The second study evaluated participant responses to JSJ for women with breast cancer. They received 10 sessions over a period of 10 to 13 weeks. In this sample, JSJ improved pain, anxiety, and the ability for participants to relax. There was no discussion of adverse effects related to JSJ in either of the published reports. Reiki is another energy therapy similar to acupressure and JSJ in the sense that the intent is to harmonize the energy flow in and around the body. Most studies on Reiki showed it to benefit participants in terms of pain, anxiety, stress, and well-being. Some participants were elderly patients with dementia suffering from pain and anxiety. Some were simply community-dwelling older adults with pain and anxiety. Others who benefited from Reiki included those with a cancer diagnosis. Unfortunately, one Reiki study found no benefit in the pain, fatigue, or well-being of adults with fibromyalgia. As I did for acupressure and JSJ, I'd like to highlight one Reiki study. This study evaluated pain and anxiety levels for adults with cancer who were undergoing chemotherapy. Pain and anxiety levels were recorded using a visual analog scale. Patients underwent a maximum of 4 Reiki treatments on 4 separate days. There were statistically significant decreases in mean pain and anxiety levels after each session when compared to before. The only time this was not the case was when comparing pain before and after a 4th session, and no side effects of Reiki were noted. In looking at these numbers, it is clear that patients perceived a significant response to Reiki in terms of pain and anxiety after just 1 treatment. So far, we've discussed the background of cancer-related pain and its undertreatment. We've also reviewed literature regarding energy therapies for pain and stress management. Now we'll talk about Manuscript 3. The remainder of today's discussion will focus on a retrospective chart review in which patient perceptions of pain and stress were evaluated before and after a first-time JSJ session. I wanted to investigate the JSJ data because I've seen patients benefit from this therapy firsthand. It's offered to patients with cancer across the street free of charge for the first 5 sessions. After that, patients simply pay what they can pay if and when they can pay, and many patients receive more than 5 sessions. Unfortunately, working in pain management, we don't refer patients with cancer to this service often enough. And I think it's because we're creatures of habit and we're so used to mainly practicing pharmacologic management. By not referring to JSJ, I feel we're failing to provide the best possible care. I wanted to dig into patient charts who have had JSJ to see what we could find regarding possible benefits of treatment. The specific aims of this chart review were 1, to evaluate the self-reported perceptions of pain and stress for patients treated in 2013 at the UK Medical Center before and after a first-time JSJ session, and 2, to examine gender differences in response to treatment. I felt it was important to begin with examining responses only to a first-time treatment. Patients don't always have the chance to return for subsequent treatments for a number of reasons. I wanted to see if having only 1 treatment would still provide benefit. In examining gender differences in responses, it would help us see if one gender may benefit more than the other. And as I noted earlier, there isn't much literature regarding gender differences in cancer-related pain experiences. In this retrospective chart review, a 1-group pre-test, post-test design was used to evaluate response to treatment. I hypothesized there would be a decrease in pain and stress immediately after an initial JSJ session when compared to immediately prior to treatment. Additionally, I hypothesized this would be true for both men and women. At the UK Medical Center, patients may receive JSJ in several different settings. For the purpose of this study, only patients treated in the JSJ treatment suite were evaluated. Those treated in other locations weren't routinely asked to report their pain and stress levels in 2013, so that data was limited. This is a photo of the JSJ treatment suite. It's a dimly lit room within the cancer center with a stained glass window and a treatment table. Most patients receive treatment while lying on their back on the padded massage table. Those who cannot lie on the table can be treated in any other way that is comfortable, whether that's in a wheelchair or on another chair in the treatment room. They can also be treated while sitting on the side of the table. Patients are fully clothed for JSJ aside from their shoes. Soothing music may be played in the background, and sessions are generally 60 minutes in length. This slide describes the inclusion criteria. In the data analysis, only adults who had a diagnosis of cancer were included. Only patients positive for pain and or stress were included. And since one aim of the study was to identify if there were gender differences in outcomes, it was necessary to know the gender of each patient. There were no exclusion criteria aside from the inability to meet the inclusion criteria. authority approval was obtained for the study before getting underway in the data collection process. Immediately before and immediately after each session, patients are asked to fill out a patient experience form. On this form, there are 3 0 to 10 numerical rating scales. One scale is for rating pain intensity, one is for rating stress, and the other is for nausea. On the 0 to 10 numerical rating scale, 0 indicates absence of symptoms, while 10 indicates the worst level the patient could experience. This is copied from the patient experience form in which patients report their symptoms before JSJ. The scales are the same after JSJ, but instead of saying prior to treatment, they say immediately after treatment. In addition to the patient experience form, there's a JSJ treatment log. This is where the practitioner indicates the date of treatment along with other information. On this form, the practitioner also documents information specific to the actual JSJ flows that were utilized. And on a third form, the patient intake form, the patient responds to several other questions, including demographics. Original copies of treatment logs are in the patient's medical records. Copies are stored in the JSJ practitioner's locked treatment room. The copies from the locked treatment room were utilized for data collection. Data forms were de-identified by a staff support person within the medical center, and a unique identification code was assigned to each patient. No individuals involved in the research analysis had access to information linking patients to their assigned identification codes. Researchers plugged all necessary data into SPSS. The primary outcome for this study was changes in self-reported perceptions of mean pain and stress scores before and after an initial JSJ session. Participants who scored 0 on their pre-session pain or stress scores were not included in the analysis of that variable. Paired sample t-tests were used to determine if there were statistically significant differences in levels when comparing pre to post treatment. A secondary study outcome was to examine gender differences in pain and stress changes. In gender stratified analyses, gender-specific differences in mean pain and stress scores were also analyzed using paired sample t-tests. This slide describes the sample. The majority were female, white, married, had some college or technical education, and were retired or not working. There were 51 total participants. 39 had pain prior to JSJ and 48 had stress prior to JSJ. Therefore, that was the number of participants included in the analysis of the respective variable. Now we'll discuss the results of the data analysis. When including both men and women, the average pain level prior to JSJ was 4.0. Immediately following JSJ, this decreased to 2.0, which was statistically significant. Stress levels shown on this slide also include both men and women. Before JSJ, average stress levels were reported as 5.7, and they decreased to 1.8 immediately following JSJ. This finding obviously was also statistically significant. This graph just provides a visual of those findings. You can see the pain scores on the far side and then the stress over on this side. Significant changes in pain levels were observed in a gender stratified analysis. In males, mean pain scores changed from 4.8 to 2.6, and in females, mean pain scores changed from 3.7 to 1.8. And this is a visual of that as well. The males are the blue triangles on the top, and then the female scores are the yellow squares. Significant changes in stress levels were also observed in a gender stratified analysis. In males, mean stress scores changed from 6.2 to 2.3, and in females, mean stress scores changed from 5.4 to 1.6. And a visual for that as well, which is a pretty steep drop. The males are also on the top on this one with the yellow squares, and then the females are the red diamonds. Now, I'll discuss several limitations that need to be considered in interpreting the findings of this study. Since this was a retrospective study, I was limited to variables that were available from treatment records. Demographics weren't recorded for approximately 1/3 of the sample, which made it impossible to examine treatment effect by other patient characteristics. Secondly, there are many confounding variables that were not controlled for, including but not limited to pain medications taken, type and stage of cancer, whether or not relaxing music was played, whether the patient was treated in the treatment chair or some other chair, but since these weren't controlled for, we cannot say with certainty that JSJ was the lone causative factor that improved pain and stress in this sample. However, I would be shocked if all these patients took both a pain pill and an anxiolytic prior to JSJ, just prior to JSJ. Another limitation is the fact that patients' pain and stress levels were shared with the JSJ practitioner through the patient experience form. For this reason, a patient may not report lack of symptom improvement. And in this study, there was only a single JSJ practitioner who worked with the sample. This makes it impossible to determine if results would be similar with other practitioners. Only including one practitioner's data was not intentional, but this practitioner happened to be the person who treated all the patients treated in 2013 for their first time in the treatment suite that had the data forms filled out. And also, there was not a comparison group who underwent a different type of treatment. And finally, patients voluntarily undergo JSJ, which may impact their reported response to treatment. Some suggestions for future research on the topic are listed here. Future research could include a randomized control trial in which patients are blinded and randomized to a JSJ group or another treatment group. It would also be beneficial to see if opioid requirements change in the 24-hour period following JSJ when compared to the 24 hours prior. This could be a good objective measure of response to treatment. In this study, only first-time JSJ results were evaluated. In the future, it would also be nice to examine whether or not patients who undergo more sessions seem to benefit more from treatment. Also, it would be interesting to see if patients of a certain age group or other demographic respond more than others. A study with a larger sample in which multiple JSJ practitioners are utilized would also help validate the findings of this study. And finally, I feel it would be useful to conduct a study where only patients with moderate or high levels of pre-session pain or stress are evaluated. This may help researchers see more of an effect because those with pre-session pain or stress levels of 1 or 2, like some had in the current study, bring the pre-session means down. That makes the post-session results appear to be less drastic than they might actually be. But with the limited sample size, it was important to include all participants. In conclusion, based on the results of the current study, JSJ appears to be a useful intervention for pain and stress management, pain and stress reduction, which are common experiences of individuals with cancer. None of the participants in the current study reported an increase in pain or stress after finishing their treatments, only potential benefits. Furthermore, after finishing their treatments, patients were asked about their interest in returning for a future session, and this was recorded on the patient experience form as well. Almost every patient, as you can see here, was interested in having a future session. This is another example of the satisfaction patients receive with this service, and this alone could prove the value of JSJ in my opinion. Healthcare organizations should utilize energy therapy practices as part of their patient care approach. These treatments help meet the holistic needs of patients, and given the findings of this and other studies, we should embrace these strategies. Healthcare providers should be willing to discuss these options with patients. They are not intended to replace medical treatments. But can safely be used in addition to usual medical treatments. It would also benefit patients if healthcare organizations offered classes for JSJ and other integrative therapies for their care providers. This would allow for more bedside staff to have the opportunity to learn about complementary therapies, making it easier for them to discuss this topic with patients and even offer the therapies themselves. Yes.
Nate, great job.
Thank you.
I don't say that to everybody, except unless they're one of our University of Kentucky College of Nursing DNP graduates, then I will. But no, really a great job. So I have just a couple of real quick questions. Did you have a JSJ session prior to doing your defense right now?
Yes. No, not. I wish
You
I
were
would
so
have
calm.
today, Jennifer.
You're not
Thank you
just
for
calm
that.
and so professional.
No, and that's Jennifer in the back. She is the JSJ practitioner who's data evaluated. No, I wish I would have today. Like bright red and burning up here, but I should have.
You've just been mentored by some of the best that are just role models.
I agree.
With Dr. O'Connell and Dr. Lowry, with contemplative sciences. But anyway, you were just right on point. But the next question I had to do with the providers in the study.
Yeah.
Were they MD, nurse practitioners, and do you have to be board certified to be a therapist?
They were not indeed, they're, are you certified JSJ practitioner?
We,
or-
at this point, we receive a certificate. We are not certified like a healing touch practitioner is certified under the Holistic College of Nursing. However, we just started a new certification program that is, we're hoping to be a part of the Holistic Nursing Association. It's in its first year at Morristown Memorial Hospital, Atlantic Healthcare. They've had Jin Shinjitsu practitioners on staff for about 15 years, and they have 20 practitioners right now.
Ooh, that's great.
Yeah.
Sorry to punt that your way. I just-
No,
I
that's
answered it a lot better than I-
But we need, an answer is, we need to be. We need to have a set standard. But if we haven't always been in the medical world, but now that we're moving that way, we need a standard. So,
Thank you.
Any other questions? Come on, y'all are too easy.
Well, I'll tell you what, you'll get some questions.
I know.
But right now, I want to thank you all for coming and
Thank
being
you.
a part of this special day. What I would ask for you right now is you could just walk outside here and make yourself comfortable in our meeting area there, and spend a little time hugging him for a moment. Well, actually, he can't go out yet. We're going to have a closed session with this committee is what I'm saying. And then I'd like you to wait around if you can, because the best is yet to come.